Well, thank you. Thank you to Sages and Dr. Porterfield for putting on this session for a very, I think, important and also relevant topic of our current climate. And thank you to the panelists who will be coming up for their talks and also for their hard work at their own institutions in terms of making robotic surgery and robotic training a success. So I'm going to talk very briefly about global evolution of robotic adoption and training. I have nothing to disclose. So first, before we talk about robotic surgery, we sort of have to talk about what is a robot. And it really is a machine that is capable of carrying out very complex series of actions automatically, and that's a very important word. What we have in robotic surgery right now is not really a robot. What we have is a master-slave system where the robot is incapable of doing any actions without the human actually directing it. The concept of this sort of came about from military research where they wanted to see if they can establish a robot that can go to the front lines and do surgery remotely and really achieve above the limitations of a human hand. The birth of the robotic surgery really started in 1998 with the robot the Zeus, which was developed by Computer Motion. And it was followed very quickly by the Da Vinci, the first one, in 1999. And the Da Vinci really proved the concept of robotic surgery by performing the first coronary artery surgery. And then the Zeus followed with a transatlantic remote surgery where the patient was on one side and the surgeon was actually in Europe. There was some fights and disputes about intellectual property, and eventually the Zeus was acquired by the Da Vinci, and it was FDA approved in 2001. So the robotic platform, in order for it to really take hold in surgery, there really needs to be three components that are in place. One is the surgeon's laparoscopic skill level has to be taken into account, as well as the laparoscopic equipment limitations and the procedural complexity. And all those three things coming together, it really first took place in urology in prostatectomies, as we all know. And the reason is because for most urologists, they do have reasonable MIS skills, but there are very few of them who's capable of doing a laparoscopic prostatectomy. The prostatectomy itself is a very complex procedure, and it really justifies using a $1 million robot to perform the procedure if it meant having smaller incisions. And the robotic instruments worked very well in a tight space of the pelvis. If you compare that with general surgery, you can sort of see why it didn't really take hold in the beginning, because most general surgeons who do laparoscopic surgery, they do have pretty advanced laparoscopic skills. The procedures themselves are not very complex and didn't really justify using a very expensive tool. And when robotic surgery first started, it was limited because it didn't have a lot of the instruments that general surgeons needed, like a stapler or a vessel sealer. Since that time, Da Vinci, and I apologize for needing to say the word Da Vinci so many times in my talk, but unfortunately that is the only platform we have, so it's a little hard to separate the commercial aspects of it. But the Da Vinci eventually came up with the XI with the boom that can rotate, which resolved a lot of the issues of docking and working in multiple quadrants. They came up with the stapler and the sealing device and the double console, which helped training of robotic surgeons. So if you look at the trend of robotic surgery worldwide, there has been an exponential increase in its use. And generally, most of it has been done now in general surgery, the increase. And whereas for urology and gynecology, it has really sort of stayed the same over the last 5 years. And in terms of placement of the robot, most of it has been done in the US, and it really hasn't expanded in the worldwide market as much as it has in the US. At academic centers, there's at least 140 academic centers across the US that now has the robot, and with over 300 Da Vinci systems in place and over 70,000 procedures being done. And the growth, if you look at the specific types of procedures that are done in general surgery, it really is the inguinal and the ventral hernias that have taken off. They've made a little bit of headway in thoracic and colorectal, but really it's general surgery hernias. And nowadays, in academic sites, about 50% of them have a Da Vinci system, and about 70% have multiple systems, multiple Da Vinci systems in place, and majority of them have a dual console. So I think a few years ago, we have been at SAGES, and we've had discussions about whether or not the robot is here to stay, or if it's just a fad, and that it's something that people talk about but will eventually fade. But I think over the last few years, it has really become evident that the robot is here to stay, and that it will become part of our general surgery practice in the future. If you look at projections of robotic surgery in the next few years, it is still growing at a rate about 8% per year, and it will double in terms of profit in the next 7 years. And most of that is actually going to come from accessory purchases and not rather the platform itself. Of course, we have to talk about the other platforms that are coming onto this market. The transenterics by Zhang was approved in 2017, and they've already sold 15 robots in 2018. And the merits of that system is that it does have haptic feedback, an eye-sensing camera, and also fully reusable instruments. There are others that are not as popular yet. There's the Flex Robotics, which is essentially an endoscope with a camera at the end, and you can insert in articulating instruments through its ports and do a lot of natural orifice surgeries. There's also the Spider, which is also FDA approved, and it's a single port instrument with articulating instruments at the end. So just to touch briefly on robotic training, I don't want to steal the thunder of my subsequent presenters, so I'm just going to say that in terms of non-general surgery residencies and fellowships, there is some form of robotic training in place for all these subspecialties. But I think for general surgery, there still hasn't quite been a curriculum or a standard of training residents. And the training of residents really depends on having a curriculum that can be incorporated into the residency training. Now having the double console technology really helps with this. And then also, right now, all the training are based on a computer-based model training first, followed by supervised training. So just one slide on the future of robotic surgery. Right now, we're in the no autonomy phase of robotic surgery, which means the robot really cannot do anything without us moving it. Eventually, it will shift toward like a task autonomy, meaning that the robot is capable of doing specific tasks if you tell it to. So meaning like if you put the robot next to an anastomosis and click a button, then they will create that anastomosis. I think eventually, and who knows how long it's going to take to get to this point, it can get to a high autonomy state where the robot is almost like a surgical resident. You don't have to do all the steps. The robots can do it, but you're sort of directing the robot to do what you want it to do. And then eventually it will get to full automation, where the robot is capable of doing anything and everything, and you don't need the surgeon around. And that's when us, the human surgeon, becomes obsolete. So, and that's it. Thank you.